So we're going to talk about restraints and the quality measures this morning. And the funny thing is that we're supposed to be restraint-free. Pretty much everybody in the industry claims to be restraint-free, and this has more slides than any of our other presentations. And most of that comes from the fact that people have lots of questions about restraints, and they get unsure about certain devices and the things that they use, and that people want to use different terminology for something. We always have to keep in mind we're looking at the impact on an individual resident, regardless of what the device is, regardless of when it's on, regardless of what we call it. Whether it's an enabler and things of that, a mobility device, we need to be looking at that and the impact that it has on restraining the patient and keeping them from doing something that they would otherwise typically be able to do. So this quality measure is actually considered only for your long stays, and the numerator and denominator are for residents whose cumulative days in the facility has been greater than 100 days. The assessments that are going to be included in the physical restraint quality measure is any admission, annual, quarterly, SIG change, significant corrections, scheduled Medicare, and discharge assessments during the selected calendar quarter, all of those things. So basically everything is going to be looked at when they're looking for the restraint quality measure. The MDS definition for physical restraint is any manual, method, or physical mechanical device, material, or equipment that's attached to or adjacent to the resident's body that the individual cannot easily remove, and or it restricts its freedom of movement or normal access to one's body. So that's a lot of words. Removes easily means the restraint or the device, the material or the equipment is removed intentionally by the resident in the same manner as it was applied. So side rails would need to be put down, not climbed over. Buckles would need to be intentionally unbuckled. Ties or knots unintentionally untied or intentionally untied. So not just because you have a dementia person or behavior person who's sitting there fiddling with something and eventually it comes undone, that's not considered self-release, and that does not keep you from having to consider that as a restraint. If you went up to the resident and said, can you take that off, and they could take it off, that's self-releasing. Freedom of movement means any change in place or position for the body or any part of the body that the person is physically able to control. So if they're not typically able to move their arms and legs and stand up, then that would not be a restraining device and would be more in line with something that was a positioning device. So the F tag related to this in a survey, it states the intent of this requirement is for each person to attain and maintain their highest practical well-being in an environment that prohibits the use of restraints for discipline or convenience, which we don't use them for those, and then limits restraint use to circumstances in which the resident has medical symptoms that warrant the use of the restraints. So we need physician's orders that are telling us that we need to use these for some sort of a medical diagnosis that warrants the use of this device. Some of the examples for restraints could be waist or lap belts, jerry chairs, hand mitts, vest restraints, lap trays, side rails. So we can look at all of those types of things. And there's other things, the bed against the wall. Having those Adirondack chairs that pitch somebody back in the seat, and so their own body weight is something that is restraining them or restricting them from standing up. Beds that are lowered all the way down to the floor can be a hindrance to the person trying to stand up because, once again, their body weight and gravity has restrained them, and if the bed was at a normal position, they would typically be able to get up. So you always have to look at the actual impact it has on the resident. People call up and say, well, is this a restraint? I can't answer that question just by you telling me what it is. We have to look at the patient. Your interdisciplinary team has to have a meeting together, and you all have to be on the same page about the impacts of what this device is doing for the resident. So trunk restraints would include any manual method or physical or mechanical device, material, or equipment, obviously attached or adjacent to, just as in the definition, but not limited to a vest or a waist restraint, belts in a wheelchair that restrict freedom of movement or access to his or her body. And then a trunk or limb restraint, if those are used, they in both the bed and the chair, you have to mark them in both sections. So sometimes you have one patient and they have two restraints, hopefully not on at the same time. Limb restraints are any manual method, again going through that entire definition, that's restricting the movement of any part of the upper extremity, the hand, arm, or wrist, or the lower extremities, the foot and the leg, that restricts the freedom of their movement or access to their body. Hand mitts and mittens are included in this category because their hands now, you're not allowing them to gain access to other parts of their body or perhaps touch or move things or pull things closer to them because they can't use their fingers. Trunk or limb restraints, again, if used in both bed and chair, need to be marked in both sections. Chairs that prevent rising. So those are the ones that have locked lap boards that place the resident in a recumbent position. So a jerry chair restricts rising, those pitched Adirondack chairs, chairs that are soft and low to the floor. If they have a cushion, a wedge cushion in them that prohibits the resident from rising, geriatric chairs, the Mary walkers or enclosed frame wheeled walkers, any one of those has the ability to both be something that is beneficial for the resident, but can also have an impact of being a restraint. So it can be both. Just because you call something an enabler doesn't mean that it's not a restraint. It can be both. Enclosed frame wheeled walkers with or without posterior seats and other devices should not automatically be considered a restraint. We have to look at them. All right, they're classified as a restraint if the resident can't get in and out through that opening gate, if they can't undo the bar, the strap, the latch, take off the tray, or any of those types of things. And typically when they have all of that cumbersome stuff attached to the chair, more likely than not, they're not going to be able to remove those things. When deemed a physical restraint, these types of walkers need to be coded at P0100G, chair prevents rising. For residents who have the ability to transfer from other chairs but cannot transfer from a jerry chair, that jerry chair would be considered a restraint for that individual. For residents who have no ability to transfer by themselves independently, the jerry chair would not meet that definition and would not be coded. Jerry chairs that are used for residents who are immobile, residents who have no voluntary or involuntary movement, that chair would not meet the definition of a restraint because that chair is not keeping them from doing something that they typically could do if they were sitting in another seating device. Bed rails include any combination of partial or full or quarter, three-quarter, whatever it is that we call them. You know, we have those bed rails there. People need to keep, if you can see in that first picture, they have those little things that keep remote controls and magazines and things within close reach. But they still have the ability to result in entrapment or some sort of other injury. So they still want us to be looking at any of these types of things. And does it hinder the patient from getting in and out of the bed without any assistance? Bed rails used as positioning devices. If the use of the bed rail meet the definition of a physical restraint, even though it improves the resident's mobility, the nursing home has to code it as a restraint. So you have to look at it. You have to look at every patient. You have to look at what's the side rail doing. Ask the patient, can you get out of bed, use this, do whatever. See if there's any hindrance for their mobility with using those devices, because that's how it would be evaluated by a surveyor. Bed rails used with residents who are immobile. If the resident is immobile and cannot voluntarily get out of bed because of their physical limitations, then the bed rails are not going to meet the definition of a physical restraint. Residents who have no voluntary movement. We first need to look at why do we even need to have bed rails then? If they're not moving around, there's no voluntary movement. So sometimes people say, well, they have involuntary or they're seizures, so we put those types of things up. And then worse yet, we put those padded side rails on them because of seizures, and then that creates a visual barrier, deterring physical contact from others, and can also be considered a restraint. Some residents have no ability to carry out voluntary movements, yet they exhibit involuntary. So they're telling you involuntary movements, residents' weight and gravity effects may lead to the resident's body shifting toward the edge of the bed. When bed rails are used, this could be a risk for entrapment. So they're telling you that even though they have involuntary movements, this sort of device, these bed rails on here, is not always the best option because they're going to end up moving over there without that control and being stuck in between there. For this type of resident, we need clinical evaluation for alternatives, concave mattresses to keep them from going over the edge of the bed. And while the bed rails may not constitute a physical restraint, they may impact the resident's quality of life. So here's all sorts of nice pictures of entrapment risks from side and bed rails and assist bars. Nothing I hope to ever see in my life. Physical restraints limit mobility and increase the risk for a number of adverse outcomes, such as functional decline, agitation, diminished sense of dignity, depression, and pressure ulcers. Residents who are cognitively impaired are at a higher risk of entrapment to injury and death because of those restraints, and it's vital that physical restraints used on this population is carefully considered and monitored. We cannot put a restraint on somebody because the family member is insisting. All right, that is not a reason. It's not an acceptable reason for you to be applying restraints. Prior to using any restraint, the IDT must assess the resident to properly identify their needs, their medical symptoms, and the restraint for which the restraint is being used. If a physical restraint is needed to treat the resident's medical symptom, and sometimes that is the most appropriate thing you can do, the IDT is responsible for assessing the appropriateness of that restraint. You need to evaluate and determine whether or not it meets the definition of physical restraint. When you determine that's what you have to use, then you want to make sure you have a signed physician order that gives the medical symptoms supporting the use of the restraint, when you should be using it, how frequently it is to be removed, when it's to be removed for repositioning, for feeding, or any of those types of things. There needs to be a signed consent that documents the education provided to the resident or the family members talking about the risk-benefit of using these restraints. And the resident should be assessed periodically to try to reduce those. So it is always coded in section P, and the intent is to record the frequency over 7 days that the resident was restrained by any of the devices at any time during the day or night. And the people are going to evaluate whether or not the device meets the definition. You need to be consistent in your practice of how you come to that determination. We can't sometimes choose that these rails are looked at this way with no standardized evaluation of that process, and sometimes we determine this, and sometimes, because if you look at your whole population and we see that there's not a pattern of how it is that you consistently look at that, then you're going to have a bigger problem. We want to look at the resident's medical records, your nurse's notes, nursing assistant documentation, and see that this restraint was used at any point in time during the 7-day look back. This is what the section looks like, and they have on here bed rails, trunk restraint, limb restraint, or other, and that's in bed. And then used in chair or out of bed, trunk restraint, limb restraint, chair prevents rising, and other. We would code 0 if none had been used, 1 if any of them were used less than daily, you'd put a 1 in there, and 2 if they're used daily. That's what we just talked about right there. Identify all physical restraints in the 7 days, determine whether or not it met the criteria. Code 0 if it wasn't used, 1 if it was used less than daily, 2 if it was used daily. If the device does not meet the definition, it is not coded on the MDS, even if it meets a technical definition of a restraint. So again, you need to take a look at the patient and the impact of the device you're looking at to make sure that you're assessing and reevaluating the care plan is all taken care of with any restraint or any device that even appears that it could have that impact. The quality measure, integral part of facility life. It's become a part of our life now. It's something we're constantly having to look at. We have the potential to influence, survey the public's perception of the facility's quality of care. The quality measures can also impact the referrals that we're receiving from some of our managed care companies. They're taking a look at those, and if you don't have a certain number of stars in either quality or overall, they're not giving you contracts. So we need to make sure, and providers need to understand, that quality measures and proactively addressing any of those issues is the key to this. Make sure when we're transmitting that we're not transmitting assessments that are used for payment only. So those managed cares, 5, 14, 30, 60, 90, we don't want to be sending those off. If the person is there long enough for the admission, we want to complete and submit an admission and not code it as an admission 5-day.